Hi there, my name is Mitesh. I'm one of the emergency medicine consultants here at the Princess Royal, and this tutorial is going to be all about sepsis. So what are we going to be covering? We're going to be covering the definitions of sepsis and septic shock. We're going to talk about causes, early recognition, and treatment. We'll also be touching on the management of suspected neutropenic sepsis in the emergency department. However, we won't be covering pediatric sepsis, which is a completely different topic in of itself. So, firstly, I want to ask, does anyone know what sepsis actually is by definition? So, the international definition of sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Quite a mouthful, but in summary, it is basically the body's response to infection. Now, septic shock is a vasopressor requirement to keep the mean arterial pressure of more than 65 or a lactated greater than 2 in the absence of hypovolemia. And this obviously represents the sickest subset of septic patients that you will see. One thing to note is that previous terminology such as severe sepsis is now officially no longer used. So why is it important? Well, the mortality can be as high as 35% in the sickest subset of patients, and this is 5 times higher than the mortality with patients with stroke and myocardial infarction. Every hour's delay in giving antibiotics in this sick subset of patients increases the mortality by 8% per hour. So if you can only take one or two things away from this particular tutorial is that timely early antibiotics are probably the most important thing you can do for these patients. So, what are the most common causes of sepsis in the emergency department? Well, the three most common causes are the chest, and as regards sepsis, we're referring to community and hospital-acquired pneumonia. The second most common cause is the urinary tract, followed by abdominal causes of sepsis, and this can be cholecystitis, appendicitis, diverticulitis, and a host of other surgical pathologies that can cause sepsis. Other less common causes are CNS, ENT causes, cellulitis, so skin and soft tissue infections, and of course, let's not forget that post-operative patients will present to the emergency department. So if you have anyone who has features of sepsis and has had surgery in the last 4 to 6 weeks, please inspect the wound sites and think carefully about whether it's related to the operation itself. Another uncommon but often missed source is sepsis related to infective endocarditis. So if you have a patient who has a prosthetic valve or even a pacemaker in situ, particularly if they've been inserted recently, please think about infective endocarditis as a cause of the patient's sepsis. So how do we go about recognizing septic patients as early as possible? Well, this will often start at the initial assessment or triage point in the patient's journey. And the slide that you can see now demonstrates what actually happens in these initial stages. So often the initial assessor, who's often a triage nurse, will firstly ascertain whether neutropenic sepsis is a possibility. If so, then there is a separate pathway to fast track these patients from triage into the emergency department to treat them, and we'll touch on that in a little while. For those patients that don't fit that criteria, the first thing the initial assessor will do is look at the patient and see if they actually appear sick or if they have a new score of greater than 3. This is the cutoff that we use locally here, which maximizes the sensitivity at triage. If the patient doesn't look sick and has a new score of lower than that cutoff, then they're at very low risk of sepsis, and we don't need to proceed any further with looking for this. However, if they do, then we do need to proceed to the second step, which is, could this be due to an infection? The initial assessor or triage nurse will often ask for symptoms such as fever, cough, shortness of breath, dysuria frequency, etc., to try and ascertain whether the patient has symptoms of an infection. Because obviously patients who have a NEWS score greater than 3 or look sick can be due to other non-infective causes such as trauma, subarachnoid hemorrhage, etc. So the clinical picture clearly plays a role as well. So the combination of a NEWS score greater than 3 and symptoms of infection doesn't in of itself equal sepsis. For the purposes of emergency department management, we also need the presence of one or more so-called red flags. These are key indicators which identify a patient as being at a high risk of death, and therefore rapid treatment is required. It is this combination of a high NEWS score, infective symptoms, and red flags which defines sepsis. It's probably worth at this stage just having a think about what red flags there might be. Well, these are derived from national sepsis guidance, particularly from the UK Sepsis Trust. And if a patient has any one of these, then we need to act quickly. So what are they? They are acute confusion or a reduction on the AVPU scale, a systolic blood pressure of less than 90, a heart rate of greater than 130, a respiratory rate of greater than 25, an oxygen requirement, a non-blanching rash, if the patient appears mottled, cyanotic, ashen, if the patient hasn't passed urine in the last 18 hours, which isn't something that we always ask in the emergency department, but it's worth bearing in mind, or if the patient has a lactated greater than 2 millimoles per litre or is on recent chemotherapy, although this latter point is covered separately with suspected neutropenic sepsis. So, if a patient doesn't have any of those red flags, then what then? Well, we need to regularly observe the patient, continue our assessments, and wait for certain diagnostic tests like imaging or blood workup. If the patient does have a red flag, then we need to proceed very quickly to the Sepsis 6 management protocol. Okay, so this next slide outlines the traditional Sepsis 6. You can see here on the slide, you administer high flow oxygen, take blood cultures and consider the source of infection, administer intravenous antibiotics, give intravenous fluid resuscitation, check the HB and lactates, and commence hourly urine output measurements. You may be familiar with this Sepsis 6 in your previous hospitals or working practices. Some people remember it by an acronym Buffalo or as 3 in, 3 out. When you remember it, it is always good to try and remember it whenever you're managing patients who are septic. And so let's go into each of these in more detail. Let's use a scenario. Let's say we have a 30-year-old female who has background of breast cancer on chemotherapy, and she's come in with a heart rate of 130, a blood pressure of 80/30, and a respirator of 30. She also has a PICC line in situ for her chemotherapy. So, what do we do with each of these elements? Well, with oxygen, we should be giving a high flow oxygen and targeting her oxygen saturations at 94 to 98%, as she has no known background of COPD. In terms of the next step, we should be taking blood cultures. Now, these should be done peripherally from a fresh vein, but also from the PICC line as well. And this can be very useful to have these paired cultures, particularly when you're trying to identify whether the PICC line itself is a source of infection. With patients on chemotherapy, they often do present atypically, and you have to cast the net quite widely in terms of considering the sources of infection. But still, the most common sources are chest, urine, and intra-abdominal pathology. Shortly after doing that, you should be administering intravenous antibiotics, and they should be broad spectrum, covering gram-positive, gram-negative, and anaerobes where possible. In this particular scenario, with a patient on chemotherapy where we might be considering neutropenic sepsis, we would usually give tazocin and gentamicin, assuming no drug allergies, as the first-line therapy. In patients who are not on chemotherapy or when suspecting neutropenic sepsis, our go-to agents would normally be intravenous comoxiclav with gentamicin. Moving on, we need to give intravenous fluids. Now, the fluid of choice will be crystalloid, and in this particular scenario, we have a young patient who's unlikely to have left ventricular systolic dysfunction. We should be giving 500 ml boluses of fluid rapidly and assessing the response. The sepsis guidelines would suggest we can give up to 30 mL per kilo of crystalloid, and this amounts to just over 2.5 liters of fluid, which is quite a liberal amount. Obviously, if you have a different patient, an older patient, or someone with known cardiac disease, you may have to be much more cautious about how you give fluids in terms of the amount and how rapidly. Next step in sepsis 6 is to traditionally check the hemoglobin and the lactate. This can be done quite easily with a venous blood gas, and we'll get the result of that quite quickly. A venous sample is often the first sample that we will get and is adequate in many cases. Finally, it is always useful to check urine output and to measure this hourly, and this would usually be done by placing a urinary catheter into the patient. There are, however, some patients who will decline this if they have capacity, and in some young patients, you can just do close monitoring of input and output without a urinary catheter. Now, all of this we need to try and achieve within 60 minutes. And this is 60 minutes from the time of arrival into the emergency department, which is quite tricky. Often we'll find that patients who resus as a priority call are much more likely to have all 6 elements within the hour. Those patients that present as a walk-in or via normal ambulance are often less likely. The key thing to remember are that oxygen, intravenous antibiotics, and intravenous fluids are the most important parts of sepsis care. At this point, it's probably worth talking about lactate and its importance in sepsis care. Everyone talks about lactate, everyone's almost obsessed with lactate, particularly as regards sepsis. But it's important to note that it is not an actual biomarker of sepsis. Lactate is a normal byproduct of anaerobic metabolism, and the levels are normally less than 2 in well and healthy patients. However, in the setting of sepsis, the higher the lactates, the higher the mortality. And as this slide shows, when you get to a lactate of greater than 4, the mortality can be very high indeed. But I must stress that this is in the context of patients who are septic. You can get a raised lactate from a variety of conditions, including trauma, running a marathon, and epilepsy. Please keep the clinical scenario in mind when you're assessing any patient with lactate. It is very useful to pick up so-called occult or cryptic sepsis, as young patients may have a normal perfusion pressure, and older patients may not have the traditional tachycardia that we would often see in the younger patients, and they may have a blood pressure which is difficult to interpret compared to what their normal baseline would be. In these cases, a venous lactate can be quite useful indeed to re-stratify the patient. Now, I talked earlier about the importance of early antibiotic administration in sepsis and how the mortality rises by about 8% for every hour that we don't give patients to the sickest patients with septic shock. This slide just sort of illustrates how useful antibiotics are compared to some of the other treatments that we often give. The number needed to treat, which is a statistical calculation. So the number needed to treat for antibiotics in septic shock to prevent 1 death is actually 4, which compares extremely favorably to such treatments like defibrillation and ventricular fibrillation, and BiPAP for type 2 respiratory failure. Of note, thrombolysis and acute stroke doesn't actually have a mortality benefit, yet many of our systems are geared up in terms of stroke teams, stroke calls, and stroke centres. Yet with sepsis, we don't actually have that set up in most hospitals. The key thing for me is that the vast majority of antibiotics are extremely cheap, and it's usually fairly easy to get them administered into a patient as long as we think about it and act quickly. So once we have completed the sepsis 6, the important thing at this stage is not to just put our feet up and high-five each other because we're not out of the woods yet. We do need to assess the patient's response to therapies. So we do this by checking the patient, seeing if they're mentating normally, seeing what their vital signs are doing, and often repeating a venous lactate sample to see if it is clearing or not. I would suggest repeating the lactate in 2 to 3 hours will give you an indication in terms of which direction you're going in. If the parameters are staying the same or getting worse, then we may need to consider escalating things to our colleagues in critical care, as these patients may require vasopressor support, mechanical ventilation, and other therapies. The other thing to remember is source control. Okay, so without source control, you're unlikely to do well with the patient. So if a urinary catheter, which has been indwelling, is the source of infection, it's important to change that. If the patient has an intra-abdominal abscess, then it's important that you escalate this to the appropriate surgical team for intervention. So please don't forget about timely early referrals to these particular specialties because they have a part to play as well. This slide just illustrates the current sepsis pathway in its entirety, which we've broken down into steps in the previous slides. Finally, I just want to touch on patients with suspected neutropenic sepsis. I've alluded to these particular patients a couple of times already. These patients are often patients who are on chemotherapy, but they may include patients who have hematological malignancies such as lymphoma, splenectomy, bone marrow transplant. These patients are particularly vulnerable to infections, particularly bacterial infections from encapsulated organisms, and they can deteriorate extremely quickly. What is also of note is that they often present atypically, often without a fever and often being non-specifically unwell. So we need to have a high index of suspicion for these patients and to treat them very rapidly. What this slide illustrates is the, if you like, an add-on pathway onto our sepsis care for these particular patients. What we need to do is to rapidly up triage them to an urgent triage 2 category and try and find them a side room in the main part of the emergency department. These patients will often walk in to the emergency department rather than coming in via ambulance, and so we need to find a space for them quickly. The key elements of their care, along with the generic sepsis 6 elements, is giving antibiotics as early as possible. And this means even if they look well with a new score of 0 and are apyrexial, that we give them broad spectrum antibiotics without waiting for the white cell count to come back to show that they're neutropenic. Assuming that there are no drug allergies, the antibiotics of choice for suspected neutropenic sepsis would be IV tazocin and gentamicin. In reality, getting the tazocin into the patient as early as possible is definitely the most important thing. The gentamicin can wait till later on if required. Patients who are allergic to penicillin will require either meropenem or teicoplanin instead. So that, in a nutshell, is ED sepsis care. So just to conclude, sepsis is common, but the most important thing is to recognize it rapidly, because unless we can do that, we're not going to be able to treat the patient. The treatments that we give are basic, readily available treatments that are fairly cheap: oxygen, crystalloid fluids, and antibiotics, but they do save lives, and particularly timely antibiotics will make a really big difference to a patient's mortality and their survival. So, thank you very much for your time. I hope that's been a useful intro into sepsis care, and feel free to ask any of the seniors or consultants if you have any queries or concerns. Okay, I look forward to seeing you.